Well, respiratory medicine is anything to do with the chest or breathing. So the common conditions would be asthma or patients who have smoking-related disease, the COPD, chronic obstructive pulmonary disease. Unfortunately, we have to deal with a lot of lung cancer as well. I've also branched a lot into sleep medicine, particularly obstructive sleep apnea syndrome, which is associated with heavy snoring and daytime sleepiness.
There is increasing recognition in the medical discipline, which is the non-operative discipline, of what are called overlap syndromes, where a second disease forms a part of that patient's condition. So, for example, a patient with cigarette-related lung disease, COPD, will have a high chance of having heart failure or rhythm disturbance of the heart, and naturally I would involve the colleagues if it's my patient, vice versa if they discovered COPD in one of their patients. So we do a lot of interdisciplinary work. The other big area we're involved is in assisting in the care of patients in ICU who have respiratory failure, perhaps after major surgery. The treatment plan, of course, will be individualised.
Yeah, I think we're very fortunate here. We've access to a huge amount of resources. So any type of x-ray that's needed, any blood test that's needed. And again, with all our colleagues, we've got so many colleagues that can help out. Usually for respiratory medicine, chest medicine, you want to know how someone's lung function. So you have lung function testing. If somebody has a problem on their x-ray that needs further investigation, they may need an endoscopy or a bronchoscopy, a little camera test where you actually look into the lungs. So you obviously have the service there. I touched on the sleep service, where we actually have monitors whilst people sleep to see how well they sleep, the depth of sleep, quality of sleep, and breathing problems during sleep.
A typical patient case from a sleep study point of view is a patient will come to Dr. Doherty, they'll say, my wife tells me I snore. I don't care, but my wife tells me I snore. It's causing marital disharmony. I wake up exhausted. I have pauses in breathing when I'm asleep. People say I can stop breathing for a minute, for longer, and this obviously upsets the bed partner. They say they're having problems concentrating, not getting on as well at work, maybe morning time headaches. Any of these things can cause a patient to present. We encourage the patients to come into a relaxed environment, usually around 2:30 in the afternoon. You may have other tests due, which we might try and fit in that evening or in the morning. Almost as soon as the patient is in, I'll come up, I introduce myself, I just introduce them to the room, their environment. We ask the patients to pop on their pajamas, and we do a lot of education with the patients. We tell them why they're here, what we're looking for, where we're going to go from here. We set them up for their sleep study. We pop a little machine on, it's very small, it sits in the centre of the chest. It's about the size of an old iPod. One of the most common things we would see is periodic limb movements. We see these on the full sleep studies we do for patients. These can disrupt sleep. Sometimes they don't, and sometimes they do, which is why we look at the brain waves while the patient's asleep when we're assessing for periodic limb movements. So something as small as a toe movement can cause a massive disruption in the sleep architecture, and something as large as a big kick out, which could wake the person next to you, might really disturb your sleep.
We have a strong physiotherapy staff for patients who have problems with sputum clearance. They're there to help them with their breathing problems. We run an excellent pulmonary rehabilitation course for any patient who's very breathless. One of the best therapies for breathlessness is exercise, but it's proper prescribed exercise course.
There's a reassurance when you come in the door. It's quiet, it's calm. You feel like you're going to be looked after there, and you settle in and you are looked after as a staff member. And in turn, you can look after the patients.
The ethos of caring, which is really handed down from the Bon Secours nuns, still is in every crevice, even though there aren't as many of them on the ground. But that ethos of wanting to deliver special care to people in need is, I think, prevalent right through the staff.